All right. Well, welcome everyone. I'm glad that you all are here. Thank you for attending, and it is my pleasure to present in collaboration with ARMC and some prime hospital locations as well. It's my pleasure to present this faculty development session with Dr. Niki on developing research, or excuse me, developing scholarship. So I just wanted to briefly introduce Dr. Niki, who I believe most of you already know, um, but he is the clinical professor of emergency medicine and the director of clinical research and tactical medicine at Arrowhead Regional Medical Center in Colton. He's also a professor of medical education at CUSM, and he's also the SBC Probation Department, CMO. So, Dr. Niki, thank you so much for being here, and I will turn it over to you.
Thank you, Jonathan, for introduction. It's a pleasure to be here. Let me just load my thing, and I appreciate everybody that joined us today for this little presentation. It's going to be quick and to the point. I've been known to be very pragmatic individuals, and just when I hit the issues, I just try to brainstorm to see how I can bypass the red tape and get the results. And that has been the story. So today I'm going to talk about the strategies for improving scholarly activities in clinical setting. And this is really comes from a perspective where you really have to build everything from bottom. There's nothing. In some institutions, you walk in and you will have tremendous amount of support. And some institutions, absolutely, you are the passionate individual who have to find the pathway to success. So why would you need a research? That's an intriguing question. The first question that comes in. So why do I need a research? How did it come to us too? So I remember coming to ARMC in 2006 for my new positions. Moved from an academic center in Ohio where we had a little bit of a support, a little bit of experience. And then I come in 2006, look around. I'm like, all right, there's nothing going on here. Then I think somewhere around 2007, they started a research day program by help of a very passionate faculty and his resident, which to date it continues on an annual basis. And that was a platform for thinking of what we could do. How do we get to be producing some research project, scholarly activities. So in 2008, I basically talked to my partners at the time, and I said, "Listen, you got to we have a residency program. It was very new. You have to do something here. You can't just be producing physicians and residents, residency training, and not have any scholarly activity." And they kind of looked around. I'm like, "So what do we have to do?" I said, "Okay, well, I'll take the research directorship pro bono." I start that way. So we started producing some abstract. We started to do a small prospective studies and hit the wall everywhere we would go. And we found pretty much uh, all the platforms that we had to resolve to get to a point where we are right now. We're in nowhere perfect. We are at the beginning again, but the steps that they have been taken to get to this point. So what you hear today is basically playing out the struggle for us to get to this point where we are right now, producing um, about 10 to 20 scholarly presentations and posters on regional, national, and international level, and then being able to get maybe about 7 to 15 publication a year, depending on quality of those. So number one is required research during residency. It does. Right now, most of the ACGME programs require a minimum, but they do have to have a scholarly activity. It doesn't mean that they have to have the residents have to have a PMID or paper publication, but they have to show a scholarly activity and track record. For the clinical faculty, on the other hand, is very different. In ACGME requirement is that they should have 3 minor and 1 major at least every 3 years, which is basically they have to produce a PMID number for the publications that they have worked on. So major and minor scholarly activities is part of that uh, product of the current ACGME policies and residency program. And also, for those of you who are in a ranking positions for as a faculty and really dedicated yourself to academic programs, like working with a medical school, or uh, I'm sure if you have a residency program or students coming rotating, you have probably connection to multiple residency programs. So the part is at least they will put you on academic promotion and ranking, and builds your CV in a sense. For me also, it's very important to do the scholarly activity because really it works on improving quality of care for patients in our communities. What we do is basically identify the shortcomings through our care and then try to address that by bringing it to the attention of the group. And it had worked over time. It had worked, showing, for example, our antibiotic sensitivity to particular infections or our method of follow-up of patients. For instance, we had a publication, a retrospective publication regarding breast cancer, and we found out that it takes average 400 days for a breast cancer diagnosed in the emergency department to have a follow-up in the clinic, which was really painful to see something like that. And currently, those policies, those reports, obviously somebody will notice and bring it to the state policies, which is changing now regarding undocumented individuals or they are either undocumented, uninsured, whatever you want to call it, is part of our community, is part of the community of humanity. So that's how we improve the quality of care for those patients when we do retrospective QIs on our databases. Um, it also brings best quality or best practice guideline, which is, as I said, in most recent years, we have done quite a few of these studies that have changed our practice guideline and how to tackle new problems. One of the newest problem that we are tackling in our area, for example, is medication-assisted treatment for addiction to opioids and other drugs. And that has been very effective to look at our pathways, our struggle, and we have published and presented our finding. And finally, I know some of you that are here today are really deep in your heart. You're passionate about research. You love the research. You really want to be around it, and you really spend a lot of time not thinking about the financial aspect of the uh, life, but really the intriguing and answering the questions of the science in regard and how you can help the others to promote through. So what are some of the barriers to conduct research and scholarly activities? Certainly, if you are part of a department, lack of interdepartment and institutional culture of research. That's one of them. It's really exists. I mean, I'm not sure how to classify that. You could name any type of difficulties in this pathway, whether it's a personality issue, financial issue. It takes a while for institutions to realize how important the research is. I could plain out tell you that we would have not qualified for a trauma centers level 2 or level 1. We just got designated for that after inspection. We would have not qualified if we would have not found a faculty group to start a research in somewhere around 2014 to take it more serious, because it's part of it. Number 2 is stigma. Some of the people really don't want to have anything to do with the problem that exists in their institutions and their communities. They don't want to identify them. And that's part of the culture. Sooner or later, and I'm hoping, actually, I see all this new generation that we have training, they have the passion to realize that addressing disparities and looking at the problem should be part of our daily life as a healers and as a physicians, as a scientists. Lack of institutional support. That's big thing for us, and it still is. We are in the infancy of that. In another word, when you don't have, for example, a office of research and grant, when you don't have individuals who can help you pull data and things like that to kind of ease up your process of doing a research and a scholarly activity. Again, unorganized GME office, you go down there and say, okay, well, I want to do this research. I want to have somebody that could manage my students, that they are coming through, they are passionate, but I want to access for them to, to the data, electronic medical record. Those are all process and obstacles that you have to resolve. We are going through that too. Even right now, we have things to place, but there are too many checkpoints that it slows down the process. Lack of academic connections with universities and academic ranks. That's another pathways. Like we are right now, we are fortunate that we have CUSM and ARMC being close up and working closely together. That allows us to connect to the some of the basic scientists and clinical scientists there, and look at their interests, look at our interests, and see what is there that we can collaborate on that. And that academic connections and academic ranking help us to get through some of these troubles. And then at the end is no financial support. Pretty much you doing the research for the sake of research, the dedicated time that you're putting in. In addition, most of the journals right now are open journals. It costs you tremendous amount of money to publish your work at the end of the day. So who supports your students? Who supports your residents? Who supports the faculty that go through? That's some of the issues that you have to address, and you go through it. It's funny because, at the beginning, I never knew that you need this much. I used to send most of my publication to the journals that were not open journals, so it wasn't costing much. But then I realized my student has to go and present that in a regional meeting, and there's no funding for it. So we used to flip the fund and put the money together. I would tell them, go get the hotel, drive, and things like that, and just give me a receipt. I'll give you a check for that. I'll give you the money for that. So that happens for years before we put something together through our colleges and also a partnership. We still don't have a much of a support for a student if it wasn't for CUSM itself or colleges itself to provide that. So what is the basic infrastructure that you really need for the research in a clinical setting? Number one is institutional review board. That could be actually a platform for a institution itself, or it could be centralized. Like, if Prime Health has multiple institutions and multiple academic endeavors, then they could all centralize, for example, and utilize USM as a platform, or one hospital could take care. One hospital IRB could be the centralized IRB for the group. You hear about centralized IRB for large institutions where they allow them to cut the cost and also be more effective. For us, obviously, we need the IRB for the county of San Bernardino, because the hospital is a county hospital, so it oversees health department, the regulatory agencies, the emergency medical services agencies. So all those, if they have to do research, they could utilize our IRB in the institution. So we are kind of like centralized too for that. And then I would say members who are really interested in research, they need to be a member of IRB. They need to push that IRB and centralize it, organize it, use that to the advantage to push the research forward. And ethical behavior also in that institutions will be under your reviews, in a sense. A dedicated faculty member to the leader, to be a leader. So as I was telling my own story in 2008, pretty much I told my partners, hey, I will take that position to push this agenda if nobody else is interested. And that is started. And then somewhere around 2014, after a few years of posters and presentations and things, and now we got to move to the second step, which is basically publication, international presentations. And at that point, we put a budget together. We had some help. The academic centers were a little bit more organized, so we bumped it up to a sort where I was able to hire a part-time biostatistician to work with me, which to this day he's working with me. And then I saw that the students also need organization, resident needs organization. I'll go a little bit more about that, but that needs to be funded. I mean, you need to be, as a faculty, one of your faculty members needs to be responsible for that, deliver report, deliver strategies to help everybody else to boost that research or scholarly activity. Uh, as I said, financial support for the rank, it's very important. Biostatistician, boy, if you can find a biostatistician that could understand the concept of medicine and work with you in a concept of clinical medicine, because many of them don't. You know, you can give them a data and they have no clue what to do with the data. Or or you could sit with them and talk about the disease and see how you could look at different perspective. You may have a data and your preliminary hypothesis have not worked to a point where you could actually address something important in your paper. In other words, it's a negative paper. But then you could also sift through your data and come up with something with your biostatistician and reverse that paper to something that addresses much more important or point out something more important in your data. So biostatistician to me, it's really a must in a research pathways. Research staff appointment, for example, I was alluding to, for example, right now, I just looked at our data, for example. In the past year, we had 39 students from our local medical school, CSN, came through our department on various research projects. There is no way that I could manage 39 students on my own. Plus, have to work and pay my bills. So you need somebody. So I created a position called research project manager. She's a part-time too, so she will communicate with them. She will set up a Zoom account. So what we do is basically a monthly research meeting, but also if their projects is getting to a point where either they need individualized help or at the end of the project, we then set up a small group research meeting. For example, some weeks, most of my nights, like evenings, 7 p.m., 6 p.m., I'm meeting with this small groups where we review their research project, or we do line by line reading. We review our data again to a point where we can meet our deadlines. Those are very important. And finally, financial support for faculty, residents, student. You could do a scholarship program, which is a summer. I know our university has that. CUSM put that program together, which works perfect to choose few students that could dedicate their summertime or additional time for scholarship programs in research. But you also have to have financial support for regional, national presentation and publications. We have, for example, 3 presentations in San Diego for our students and residents that are going. Now, there are some funding that supports the residents, but the funds for students is very rare. So either has to come from medical school or it has to be coming from the faculty putting it together, which fortunately, I have good partners to think that, okay, well, he's a student or she's a student, we need to support them to go through the process. Publications are going to be very costly too. And we'll go through some of that, but it could be anywhere between $350 for case report to upward of $2,500 for your paper in open journal. And if you notice, majority of the journals, other than top tier 1, have moved to open journal because they can't really afford publish everything without financial support. So most of the tier 1 also getting support by their institutions to supplement that. Probably the most important step is developing a culture of mentorship, which is strengthen your academic programs. So that starts with transparency. In other words, I work with the students and residents. If they have put on their time back there, I'm going to credit them. Go back to my own experience when I was in a PhD program or my master's program. I used to do a lot of research and data mining and data work and simple labs. And at the end of the day, either I end up in acknowledgement section or not at all. So that's a culture that I don't follow. I fortunately had a good mentor, Dan Ely, um, who was a big time researcher on hypertension and cardiovascular disease in Akron, Ohio. And he taught me that, we really need to be um, uh, crediting everybody that is part of the project. So, being in a position of senior author is good enough for me for majority of the projects. Although most of these projects are my ideas, my timeline that I put in, but you have to basically create that mentorship program to encourage these young kids that are coming through your program. So they will be the future mentors for everybody else, the next generation, so to speak. What worked for me is division of labor and basic understanding our capabilities. In other words, let's say you have, many of my projects are focused on trauma and peri-hospital care. So what I do is basically I have a partner in trauma department, or a few of them. I have partners in anesthesia department and the emergency department. What I look in, okay, it's my idea. Let's talk to this guy, get some perspective from him. I want him to be the editor. I want him to be the participant. I know he doesn't have that much time, but we'll put this together. So the residents and the students work the project with me, and periodically he will review the process to see if we are in the right direction. And that's the possibilities. So what is his capabilities is basically his mindset and experience regarding that particular projects or disease process that he's expert in, and can give me a perspective of direction, being in the right direction to finalize that project. Again, remain humble in the structure of authorship, whether you're first or the last. Give a credit to everybody in that regard. Uh, one thing I have in mind when I moved from PhD program to medical program was basically to change the dynamic of the process. I'm not in this stress that I have to be a first author in all the projects that I have. I don't have that. I don't have that perspective. So majority of my project, I'm the last author as senior author, and allow the other guys to grow under my supervision. Support your residents and the student in every aspect. Um, with time, money, you would need. You need to be generous if you have to push research. Research, um, unfortunately, research never been about the money. Even if it's a grant base, it takes a lot of time. Those who have gotten a grant, they know how much work they have to put for that. By no means, corresponds to the amount of work and energy they put in. But for us as a clinician, we have that capability of being a little bit more comfortable financially. So I support my student and resident as much as I can whenever they need to go. And obviously, as I mentioned, developing mentorship programs. One of the big things that I have is basically I bring in students from high school right now. I bring in students from college when they approach me for research. I mix them with the medical students and residents. While I'm with them, I tell them, you guys have to mentor each other. Uh, and I sort of like choose the leaders from the group to take that stress out of my shoulder, but it's not like I'm leaving it alone. I'll try to make sure that I check on them to make sure that process is appropriately done. Factors that influence your success in the program. Obviously, infrastructure is first. Okay, it can be time consuming and very frustrating at all time. Okay, even right now we putting a lot of time because one of the issues that I'm gonna tell you about is that as soon as somebody find out that one of the faculties are interested in research, what do you think is gonna happen? Everybody's gonna flock to you, and if you don't know how to say no, you're gonna be having a multiple project at the same time going, and that's not really your life. You weren't hired to be a research director for institutions. You were hired to do your job as a clinicians, and in addition to that, you picked up this additional responsibilities. So there has to be a support for you, and your time has to be really strategically placed there. Pick up appropriate projects for yourself. Obviously, prospective studies in any capacity, prospective double-blinded, prospective observational, are very challenging. I would say if you are in a early stage, choose retrospective quality studies, case series, case report. Just to let you know that if you guys, some of the big institutions do not take the case report anymore. They want a minimum of 5 cases as case series. For example, the American College of Surgeons just started. They will not count case report as your qualification for trauma centers. It has to be at least a 5 case or above. So strategically approach that. Otherwise, it will get frustrating. Prospective studies, it's very time consuming and labor intensive. Put a team together, people with various skills, as I alluded before, like, make sure that medical student that approach you or resident that wants it really is passionate about the project before you assign it to them. And then have a structural timeline for finishing that project. And that's very important. I usually carry about 10 projects at the same time. Right now, maybe we have, additional 5 or 6 of case reports or case series, but our main projects is probably about 10. And when I do that, I try to find those who are truly interested in, and then put a leader, a faculty leader in that group. And then I check mark with those faculty. Does it go always smoothly? No. You still have to check on it. What's going on. It's been 2 months. There is no progress in this project. So you put a Zoom together or meeting, personal meeting, whatever you have to do to get the team motivated again to refocus on the projects. And then it's very important also to get connections, finding connections and networking. And the way you do it is participating in a both internal, like regional research day, or internal institutional research day, or in this case, for example, in my opinion, prime hospitals should participate with CUSM probably in annual research day, where they can present their posters or projects, and then also find connections and networking with faculties that are interested in their pathways, and that could be a really good platform for connecting with the basic scientist, or bench scientists, or scientists that has some experience in a grant writing or grant follow-up or grant structure through universities. So how can I retain faculty in academic medicine? It's very difficult. I'm going to tell you this. Most of our faculties barely qualify in ACGME requirements currently for their major project and minor products. And even if you look at the large institutions, some of the criticism they bring in, well, there's only a few of you guys, but you get publication together. Yeah, but we work together. That's not a good criticism. If 5 of us working together and you see 2 or 3 of us repeatedly in the paper, it doesn't mean that we're cheating or something or doing something unethical. We're close to each other. We can work together. We understand. We can meet together. I have a faculty that has not missed a Zoom meeting with me to sit and do a line-by-line reading up of a manuscript before I submit that. Isn't that crazy? Like you really have to find, crazy people like you who are interested in research to help you through these projects. Otherwise, you're going to be sitting down there lonely, and none of those projects can move forward. It will really get so. Work with the department chair regarding these issues. If there is funding, if the hospital can help, put a fund together for the faculty's hiring, or institutional research director would be another one. That's through GME office, through the C-suite, work with them to have a strategic planning, because hospitals also know that they need the residency program and the scholarly activities. They know that residency program actually is financially beneficial to them and also leaves a legacy there. For prime hairs, for example, spending a lot of money on opening a medical school, it could be a pipeline for those medical students to come to the prime hospitals and also leave a legacy down there that they did something for the community in regard to increasing the physicians in an area where there is a physician shortage. So there is financial benefit to have these programs, and as a result, you could put that ahead in terms of discussion with this C-suite and GME that we need help. We need a biostatistician. We need individual to manage our students in research projects and residents, help them to find champion in the institutions, to encourage the institutional culture of research. What is institutional culture of research? Meaning that you're not the only one who's doing research. Every department, including nursing department, including staff in administration, have some sort of project continuation with you. If it's a quality of care, certainly C-suite individual will be interested in that. If it's quality of patient care, nursing staff, we have had multiple publications with some of our nurses that are bright and have a lot of potential, especially writing skills, capability to review the literature for you. Then connect with sponsoring universities, like as I spoke before, like CUSM is an example. But we have, for example, 5 different, universities that have some sort of contract right now with our institutions. We can also connect with them and say, hey, I'm taking care of your student and they need funding. There is funding. If the student is rotating in your hospital, they're getting money. And that money needs to be allocated appropriately also in regard to research and scholarly activities. It can't be all about clinical rotation. Maintain a healthy level of scholarly activities. Again, don't let it get out of control. As I said, your department could be like the prime department in that hospitals, producing a lot of scholarly activities. And then suddenly you see barrage of email coming to you. Dr. So-and-so, I'm a student from this college. I'm interested in research project. And they are bright students. They really want it. But then you also have a limited time. You really need to choose. So some students actually work with me for years. I've had a student that worked with me for about 3 years before he went to UCLA for residency, and he's still working with me as a faculty. And became a good networking for me. So it's very good. It's always remembered you. And, I grew up in a culture of respect to my faculty, never call them, those who trained me, I never call them as a first name. It's still Dr. So-and-so. So it's a legacy that we're putting there. Support the faculty really and to impact their career interests. For example, you notice in the early stages of faculty coming up, their focus is really financial. They have to pay their loan. They have to do. They're not interested in extra curricular activity unless they have to. But if you truly throw some, small projects, small interesting issues, small support for their projects, they will take it. And that's a good point of retaining those faculties if you see potential in them. So how do we work as a motivated team? Do a division of labor. Okay, so what I do is basically have students work on introduction and literature search at the same time. So I basically open up a Google share document, connect to those who can edit with me and go and writing process. While we're doing the IRB application, we also do the introduction and literature search. The method, we know it from our IRB application, retrospective, prospective. A results section will wait till senior faculty or senior author plus the biostatistician work together on the data, finalize it, make sure everything is accurate, because a faulty data can basically be like plagiarism. So you have to make sure that you always double check that. I can't tell you how many times I went back and looked at the result because it doesn't make sense. So as an experienced physician, you look at the result and you say, okay, well, how can a cardiac arrest post-trauma come to the trauma room, get a thoracotomy, get double chest tube, and the ISS score is 0? We had those. So I had to go back and look at it, rescore them, and make sure that data is correct. But that's the part of reality. You have to be on top of it. And then discussion, obviously. So introduction and discussion, your student and residents actually can pull all that supporting literature at the same time and then work on to refine it. And you basically say, okay, so and so guys, two of you can start the introduction and do a lit search, while another faculty with you will do reconfirmation of that result section and literature search. And then at the end, everybody does the editing and re-editing and final re-editing before the submission. How do we work as a motivated team? Again, you can publish your papers if you keep consistency and dedication. Meet the deadline. Okay, so you put a deadline. Hey guys, I want in 2 weeks. I want the literature review and see if this is a good idea before we start the project. And that's the other thing. After 2014, I decided that if I'm touching a project, at least I have to know that there's 80% chance of publication, and don't let it hang around and sit around, because there are projects that by the time you want to publish, 10 other people publish before you on your idea, that original idea you had. um, I have quite a few of those examples. So that's ultimately that's where I came in, that anybody that works with me has to meet the deadline or you're out, and that puts the pressure on those people. Make sure that you consult your biostatistician early in the project about the design, about the primary outcome that you expect, to assess the study's structure before you start. Because really, it's before even IRB submission, because it could be really disappointing to do a research and then not get the end results. Some of the collaborative example that I could show you. For example, we did a study that took about 4 years. That was probably the most challenging I had, to look at TXA in civilian trauma. By the end, we finished. It were probably about 5, 6, no more than that, probably about 10 different institutions involved with me, but also took about 4 years of prospective data gathering. And it was really labor intensive, but we were able to publish that and became the largest study in actually American continent, North and South. And it's a very controversial subject. To this date, they're still publishing about the subject. But, or, in the cases of management of traumatic esophageal hernia, this was a patient that comes through the trauma. And I look at it and I said, I've never seen a case like that. I do right there, quick lit search. And I tell the surgery resident, hey, you can write this. There's nothing out there, very few. And we get on it, and in 2 months we had an article published through that. All this, again, find your champions, find collaborative projects between the institutions. So in summary, investigate the overall process in your institutions to make your life easier. You have to really address that. Like Boyer said, 4 type of a scholarship or a scholarly activity: integration, teaching, application process, discovery process. What are we going after? Make sure that you have a strategy and you follow that. Developing a scholarly activity program, it's very important. Mentoring as a buffer uh, to impact those scholarly activity and future of it. Create a culture of research, and then ultimately you are unique. And I'm going to put this here. This is really by Boyer. We need a climate in which colleges and universities are less imitative, taking pride in their uniqueness. It is time to end this suffocating practice in which colleges and universities measure themselves far too frequently by external status rather than by values determined by their own distinctive mission. But what is our mission? What is your hospital mission? What is your practice mission? What is your community? We did a publication on effect of methamphetamine on cardiomyopathy. The idea was, I saw a paper that was done by 4 institutions about people in Hawaii. And I'm like, how can you apply Hawaii to San Bernardino? And we did that, and we found that we had even worse, those cases. And it was published in Journal of American Cardiology. So you have to determine what your environment is, what your patient's population is, and how can you impact. And don't worry, don't look at these clouds around you, clouds of judgment and things like that. Research, on the other hand, I have to also add that it became very political. Like, you send your paper to one paper, you're expecting that it's being published, and you realize that these guys are, becoming like blue and red here. uh, it's becoming more challenging for everybody to that. So you need to not get frustrated, and there are a lot of opportunities for you to push your manuscript when you do that, based on uniqueness that you have, unique information that you present. These are my references, and I'm going to put my contact information here. Of course, Jonathan has it. If you guys have any question, I'll be at your service. Throw me an email, send me email with your question. I'm going to, since we have a little time here, I'm going to leave a few minutes for discussion uh, and question that you may have. I'll be more than happy to answer that.
Thank you, Dr. Nikki. Any questions for Dr. Nikki? Comments? Can springboard off of any of those ideas.
Again, anything comes up later, I'll be more than happy. There is a question. Go ahead, Gordon. Is it comment or you can?
Well, it's a bit of both. So
Okay,
first
good.
of all, Dr. Nikki, thank you very much for taking the time and preparing this for us, because I think that this is an area that, as you mentioned, we across Violet Street really need to to be expanding upon, and it's also the opportunity that you and I and others on both sides of Violet Street regularly talk about, with regards to an opportunity for us to get to closer together as a collaborative partnership. So I think that I really appreciate all the work you've done generally, but also with our students. And I would very much like to offer you opportunities over here, not only to talk to our students more, but to help them engage in research projects. We have a scholars program that I think could really benefit from your experience and just the ideas that you have to move projects forward. So
Yeah,
I
I do.
will.
Thank you so much, Gordon. So that Green, that we have had close relationship in the past few years since the start of this USM, and I think that that's the process that we have developed, at least to, and a lot of publication with the students that went through. So the mentorship program is working, but I would say, I'm still humble, and I would say we are still at the earliest stages, infancy of building on that projects. Yes, I'm actually tomorrow morning. I'm there talking to your student. I do that every year. That's how I'm getting a lot of attraction by from the students from the CUSM, which I always enjoyed. It. They are very bright uh, uh, horde of a student. Any faculties from any other hospitals that are here, I highly recommend the CSM students for your project. They really met all the deadline. They show a lot of passion. That's what I enjoy about it. I probably, like, in maybe year one, I had one guy that halfway a project left, but everybody else delivered. And some of them actually are multiple projects with me because they learned the process. Now they know how easy it is to write a manuscript or work on a research project. So that's the part where we have to teach them that don't be afraid. Take the first step, and I'll teach you. I'll take your hand through the process. I'll give you credit for it, and you build on it. And that's what they're doing. I see, the summer projects, obviously summer scholarship from the university have worked perfectly. I've had, I'm not sure now, but initially it was upward of 10 or more than 10 students that were participating in our projects. But what I would suggest is that halfway before the start of the summer, you should probably give a heads up to the faculty that I have a student, because I've noticed like some of the students wait till they are approved for the scholarship, then they approach the faculty, and that kind of eats up some of the time that they were already allocating for the summer scholarship program.
Yeah.
So that's what I told them. Actually, none of them did doing their projects under rotation. Okay, they are doing it under basically a year-long project attachment, which as a result, the financial aspect of the hospital is not connected to that part. Okay, so if they were doing it as a rotation, the finances would come with them as a rotation. But we haven't developed that one, so that could be a year-long actually project for some of these students. But I would say your students are fantastic, and it's 99.9% I had success with a student. They are really dedicated. So all the faculties should really benefit from that process.
Dr. Nikki, we have a question from Dr. Talib who asks, excellent presentation. Can you comment on the difference between QI projects and research and how QI can be turned into research?
Oh yeah, very good question, Dr. Talib. Thank you so much. So we are basically looking at shortcomings in medical care or discrepancies that we had in population health. And usually we address that as a QI. Okay, in other words, something went wrong with the patient care, something did not work, our process is not working. And what we do is basically I say, okay, well, let's look at it. Is it the only case that happened? Maybe we could do a retrospective data mining here to see how many cases we have had like that and what was the outcome and how can we improve the process. And that's despite, so this comes from a presentation as a quality improvement projects as a case that we have missed in M&M or something like that. But then you can turn that as how can I improve the process? Okay. Something also I think that Talib and everybody is familiar with is that our culture for years in medicine has been blaming rather than improving. Okay, this doctor missed, therefore he's a bad doctor. But nobody came and looked at it. Okay, is the system also to blame? If a patient does not get from point A to point B to do the test in a timely manner, if the patient from A does not get to B because that patient doesn't have insurance, what happened? It's a process, not the doctor to blame for. So what I do is basically I look at either process or quality of care, and I turn that as a research and see how we can improve that thing. When we talked about, for example, breast cancer, these were newly breast cancer diagnoses in ER. These are people that come in with a breast mass and we examine them, we do it. So over time, we improve that quality of care. Now we have a process where whether you are insured, uninsured, documented, undocumented, that person will get a follow-up with an ultrasound, mammogram, surgery clinic, and then comes back. So many of these guys may not even see the primary doctor. They already got the care. So it had improved that discussion process. And that's how we convert that, in my opinion. And there is plenty of opportunity in this hospital in what they call is basically a point of care or quality of care hospitals. We are a network where people need us, so that's what I could say in a nutshell, so to speak.
Thank you. Any last questions? Seeing none in the chat at present, but we welcome further questions if you have them.
What I want to emphasize again is invest on your uniqueness and the unique environment that we live in. I appreciate the opportunity, Jonathan. I really enjoyed it. Thank you so much, everyone.
Thank you so much, Dr. Nikki. Thank you, everyone, for attending. I appreciate it.
Pleasure.